Here at South West London and St George's, we've been working on an improvement project to improve physical health outcomes for people living with long-term mental health conditions. Like many other mental health trusts in the country, our information system showed that before the project, only 25% or so of eligible people were accessing the relevant cardiometabolic assessments for checking cholesterol and glucose that can indicate a need for interventions to reduce risk.
We looked at how we could apply a quality improvement methodology to this problem, and we brought staff and some service users together. We had a series of rapid process improvement workshops, really to help us understand what the barriers were and to generate some good improvement ideas. So from these events we got some really good testable ideas for fairly rapid improvement. There were some community mental health teams who were doing some really good work. They were incorporating physical health checks into routine outpatient appointments, into CPA reviews and into clozapine clinics, for example. And we wanted to standardise that and share that across all teams. But we really also wanted to integrate our processes with primary care, where most of our patients you would expect to go for their physical health review. And we were able to rapidly scale up access for clinicians to the pathology results for blood tests around glucose and cholesterol that GPs were conducting anyway. Some patients, however, needed a more proactive approach, and so we tested out the use of relatively cheap point-of-care blood test machines, and these can measure cardiometabolic risk markers from a drop of blood taken with a simple prick of the finger.
We have implemented the cardiometabolic assessments in our service, and we have achieved a good result, and the reason we've been able to do this is for a number of reasons. First of all, we have dedicated 2 staff to focus on it, which has been a trainee doctor and a recovery support worker. They've 1 day a week held a CMA clinic so that care coordinators could book their patients into that clinic, and where patients weren't able to come up for it or decline coming up for it, then on that dedicated day the doctor and the RSW would go out and see the patient at home where necessary. We did make some important discoveries when doing CMA checks. We found there were a few patients who had raised prolactin levels and a few patients who had high glucose, indicating possible onset of diabetes. So it was a very useful project, and we're pleased that we managed to uncover these examples.
Within 4 months of the first workshop in July 2017 and trialling the package of improvements that we developed, we've moved from an average of 23% of eligible service users having an assessment, a full cardiometabolic assessment in the previous 12 months, to over 70% at the end of November 2017. And this is against a national target of 65%. So we've exceeded the target. However, we've still got room for improvement, and we're going on with the help of our service users to revise our patient information booklets. These will give an individual record of the tests to the service user, including a calculated future risk for stroke and diabetes, and to give prompts on graded lifestyle changes, advice, and graded interventions to help to reduce the future risks of ill health.